Okay, 8:01, let's get started.
All right. Well, good morning, everyone. My name is Bob Harrington, and it's my great pleasure this morning to introduce to you Ruanne Barnabas. Ruanne is coming back to us from the East Coast to talk to us this morning in Seattle and at Harborview. Ruanne was a faculty member here for a decade, rising from, well, not so humble beginnings as a fellow to full professor of both global health and medicine in a decade before she was abruptly stolen from us and hijacked to Harvard, where she now leads the infectious disease division at Mass General Hospital. Ruanne has spent her career studying interventions to prevent HIV and STDs, and most recently also focusing on ways to intervene and prevent the spread of COVID-19 among household contacts. She is a brilliant physician and researcher, and so delighted to welcome her back this morning. Her talk is Health Economics in HIV and STIs. Thank you very much, Ruanne. It's wonderful to see you.
Bob, thank you so much for that very warm welcome. I'm really thrilled to be here, to be among friends, and I am really happy to present today on integrating health economic analyses into STI and HIV research. And certainly I'm here today among friends. Please feel free to interrupt with questions in the chat or with, which I won't be able to see, but maybe Victor, you can alert me or to come off mute and ask questions. I want this to be an opportunity for everyone to think about integrating health economic analyses into STI and HIV research. The way I am going to present the talk today is to tell a story of a study that we did, building on the work of many people and how we integrated health economic analyses. The aim of doing this is to present to decision makers a whole set of data, not only the efficacy data for interventions, but also the cost and the cost effectiveness. So I'll provide the rationale for why we do this, and then talk through the steps of health economic analyses using models to estimate health outcomes from study data, how we estimate the cost of interventions, how we use both those things to calculate cost effectiveness, and then end with a discussion. So why are health economic analyses necessary? And you can see some reasons why they're necessary here on the slide. But maybe I'll ask people who actually chose to attend a talk this morning on health economic analyses to put in the chat, which I've opened up, why are health economic evaluations necessary and helpful? Why did you attend this talk today? Is there a specific question you're thinking about answering where health economic analyses might be useful for you? And while you're typing, I will read through what I have on my slide, thinking about what's useful. So we put here that we have a limited budget for health interventions. We want to maximize the health benefits for the budget that we have. We want to compare different ways to address the same health problems. So for example, I'll talk about today, what is the most efficient intervention to identify people living with HIV in the community? We might also want to be able to compare different health interventions to determine which ones maximize health benefits. So for example, should the Kenyan government fund rotavirus vaccination or HPV vaccination? Since we know that funds are limited for interventions, health economic analyses help us make some of these decisions on how to use our resources. Do feel free. I see some people here who are participants who are very much involved in programmatic decisions, and so I'm sure have reasons for wanting to know the results of health economic analyses. Feel free to put that in the chat as we continue today. So in general, health economic analyses compare the change in health, which is measured or modeled, and the change in cost. And I really want to emphasize here that it's the health outcome that's most important, whether or not you can avert morbidity and mortality. So in classic health economic analyses, it's not enough to provide services or even indeed to deliver services or actually even to reach people. It's whether or not you're able to deliver the intervention to prevent morbidity and mortality. And you compare this change in health with the change in costs. And the change in costs can be measured or they can be estimated. And the change in health can be measured or it could be modeled. So for example, we might prevent persistent HPV infection, and then we can model the impact on cervical cancer. And assumptions in the modeling and the costing drive the outcomes. So where you are estimating or modeling outcomes, these really drive the findings of cost effectiveness analysis, for example. So when you're reading papers about cost effectiveness analysis, pay attention to the assumptions. There are 4 types of economic analyses, just kind of broadly speaking, and I'll talk through each of these now: cost minimization analysis, cost benefit analysis, cost effectiveness analysis, and cost utility analysis. Cost effectiveness analysis, in cost effectiveness analysis, costs are valued in a dollar amount. The health benefits are valued as clinical outcomes, example, HIV infections averted or HIV-related deaths averted or years of life saved. And you can see that each of these outcomes are associated with the cost. For HIV infections, for example, you have all the costs of providing care for people living with HIV. And these results are reported as a cost effectiveness analysis. I'll just go back and say very quickly that for cost minimization analysis, we look at different interventions to minimize the cost of delivering the service. A cost benefit analysis is really done in healthcare because that compares both the costs and the benefits and assumes that if the benefits don't outweigh the costs, the intervention will not be delivered. And this is often not the case in medicine. And most often we use cost effectiveness analysis. And then cost utility analysis is a special case of the cost effectiveness analysis. For cost effectiveness analysis, we report the results as a cost effectiveness ratio. So the incremental costs over the change in health outcomes. When might you do health economic analyses? When in your project, from the time of conceiving the idea to testing it in a clinical trial to implementing an intervention, would you do health economic analyses? And actually you can do it at any point. It can be entirely theoretical. So it could be entirely in a desk study. It could be tightly tied to a clinical trial, which I'll show you today. And then ideally, economic analyses would be part of implementation science and part of ongoing monitoring and evaluation for programs, helping us think about how we really maximize health outcomes for the resources we have. And so now I'll shift from the rationale why we do health economic analyses to talking about how we use mathematical models to estimate health outcomes from study data. So first I'll tell you about a study which I hope is relevant to many people who I see at the meeting today. And I'll start by talking about the different types of models that we have in health economic analyses. We structure models to answer economic questions and compare all the relevant alternatives. So for example, we can extrapolate beyond observed data. So models for HIV, we classically use them to extrapolate from data on viral suppression to incident cases averted. And we can do this because we know that people living with HIV with a suppressed viral load don't transmit HIV, and so we can estimate the number of cases averted. And so we're able to use data from clinics, from clinical trials to estimate the impact on new cases of HIV. We can also use modeling to link intermediate and final endpoints. So for example, we might have the number of cases of dysplasia or persistent HPV infection, and we can use that to model and estimate the number of cases of cervical cancer. And so if we have interventions that prevent HPV infection or treat dysplastic lesions, we can estimate the impact on cervical cancer incidence and mortality. And you'll recall that both those health outcomes are needed to estimate cost effectiveness. And then we can use mathematical models to generalize the results to other settings or patient groups. So for example, we might have a study conducted in South Africa, and we can change in the model demographics and other pertinent information like the program information to model the impact in a different setting. And then we can use models to synthesize comparisons where randomized controlled trials don't exist. We have many potential groupings of different interventions, and where we don't have individual randomized controlled trials on each type of intervention, we can use math models to simulate these data. And then once we have validated models, they can be used to estimate the potential impact of interventions. So example, antiretroviral therapy for HIV prevention. There are several types of models: static models, which are linear; dynamic models, which we use almost always for infectious diseases. Because we know that the force of infection can change over time, as actually as we're seeing with COVID, as herd immunity increases and decreases, as variants change over time, dynamics models allow us to capture these changes over time, both from a viral perspective and from a host perspective. So when we model infectious diseases, we almost always use dynamic models. Both static and dynamic models can be either deterministic or stochastic. And if they're deterministic, they give you the same answer every time. And if they're stochastic, they contain some constrained random variables. So for example, for COVID-19, we can think about the emergence of new variants as random. And so in models that try and capture SARS-CoV-2 transmission, you could include stochastic variables. And the choice of the model that you use depends on the scientific question. And for infectious disease modeling, we almost always use dynamic models, but there are some specific circumstances in which we might use static models. So I want to take you back now to 2008, where Ruben Greenwich and Brian Williams published this math modeling paper on the impact of ART on the number of new infections in South Africa. And they predicted that if within a year, you could test everyone in South Africa and link all people living with HIV to antiretroviral therapy within a year, and 90% of them achieved viral suppression, you would see these dramatic declines in incidence, in prevalence, and in mortality. And of course, this kind of simulated scenario was ambitious. There were many comments after this specific paper that the modeling part was easy, but it was actually the implementation that was really challenging. However, this paper did serve to make us think very deeply about how we could actually reach people living with HIV, and actually continues to serve as a reminder that the ultimate goal of widespread testing and access to medications, reaching priority populations, people who are vulnerable, people who are otherwise outside our current services, has the potential benefit to have very significant benefits for the individual, but also important benefits from a public health perspective at population level. So building on that work, we went on to conduct the DO-ART study. It was a community-based antiretroviral therapy study for standard clinic-based services versus compared to community-based services conducted in South Africa and Uganda, and was conducted with a great group of collaborators at the University of Washington, at Harvard University, at the Human Sciences Research Council, at the African Health Institute, and at the Integrated Community-Based Initiative program in Uganda. And this study combined models with realistic assumptions to eventually estimate the impact on health outcomes. But I'm going to talk you through all the steps from a clinical trial to estimating costs to doing the modeling, and then finally estimating cost effectiveness. And hopefully I'll show you why it's worthwhile to pursue all these steps. So the study was conducted in the Shima district in Southwest Uganda and in KwaZulu-Natal, South Africa. And it estimated the impact of a package of interventions: community-based home HIV testing and counseling, same-day ART initiation, and mobile van monitoring and refills. And there was also the option of being tested and starting ART at the mobile van. The outcome of the study were viral suppression at 12 months after testing, the cost per person virally suppressed, and we wanted to assess specifically the impact in South Africa among South African men due to the large gap in viral suppression between men and women. So here's the locations for the study. You can see here in KwaZulu-Natal, where HIV prevalence is very high, 27%. Viral suppression at the time of the study was 54%, 47% in men, and in Uganda, the HIV prevalence was 10%, viral suppression was 64%, 55% in men. And to briefly review the study design, people living with HIV who are not on antiretroviral therapy and clinically stable, actually for this study had a detectable viral load, were randomized to one of three study groups. The clinic group, where ART was initiated at the clinic and ART monitoring and resupply continued at the clinic for the course of the study, or the hybrid group, where ART was initiated at the clinic, but monitoring and resupply continued in a mobile van, or the community group, where ART was initiated either at home or the mobile van, and monitoring and resupply continued at the mobile van. For people in the community group, it was possible for them not to visit the clinic at all for HIV care for the course of the study. And the primary outcome was viral suppression, a viral load of less than 20 copies per mil at 12 months. And we planned a priori to test for non-inferiority if the intervention was not superior. And here are the study partners and where they're located. These nice maps show HIV prevalence, the darker color showing higher prevalence, and you can see that we chose high HIV prevalence settings, and working with our colleagues, Dr. Stephen Asimwe, Drs. Miriam Shamanesh and Dean Pillay, and Professor Heidi van Rooyen, and the management team at the Human Sciences Research Council, Alistair van Heerden, Tulani Ngubani, and Philip Joseph. And we've actually been very fortunate to work with our collaborators for many years on these types of community-based projects. And I wanted to share with you some of these pictures so you can see what it's like. So testing is conducted at home or mobile vans. And here's a picture of a mobile van with, and these are the study team members. And ART is initiated in the community, and we're able to convert some of these vans into quite useful settings. There are fridges, so we're able to maintain temperatures for specimens that we collect. All the data is collected electronically and uploaded. When Wi-Fi is available, we're able to provide refills and monitoring. Many of the tests were point-of-care tests, including creatinine and CD4, and we collected plasma for viral load. All the participants who were in this clinical trials remained clinic patients, and so we were able to update the clinic records using, in South Africa, tier.net, and in Uganda, we updated the clinic records by hand in the paper charts. But patients remained clinic patients, but received their care outside the clinic through these mobile and community-based services. Testing was conducted in the community, and actually, if you haven't been to KwaZulu-Natal, it's an incredibly beautiful province in South Africa. And here are some pictures from the foothills of the Drakensberg Mountains, showing the communities where we conducted the DO-ART study. And can someone put in the chat, can you see in this picture the Do Art study van? This is very much science embedded in the community. So if you can put in the chat where the Do Art study van is, if you can see it. I do recognize many of the names on the participant list. So I might actually even call on someone if there are no volunteers. Can anyone see the Do Art van? I'll keep talking while you're chatting. Sorry. Okay. So to be eligible, so Tim says he sees a truck. And thank you. Bob can't see it, but I'll show you where it is in a minute. To be eligible, participants had to be clinically stable, had a CD4 count of more than 100, and not on ART, and for this study, had to have a detectable viral load. Community-based ART was nurse-led. ART was initiated in the community. Refills and monitoring were provided quarterly, and we were able to update their patient charts. The clinic-based group received standard services at the clinic, and then everyone completed an exit visit at month 12 with viral load measured. So you were randomized at the beginning and continued through all the procedures, and then we found just about everyone, 98% of people, for viral load at the end. So someone says it's here at the bottom right, and I'll show you. Here's the van right here. So here's the Do Art mobile van. Well done. Great. I think someone did, Tim, I think you did see it. So I'll move on now to talking about the results. 93% of people screened were clinically stable. So the median viral load, the median CD4 count, as I'll show you, was quite high, almost 400. So we tested over 8,000 people, of whom 2,479 were living with HIV, and randomized 1,315 to each of the three groups, 446, 442, and 427 to the clinic, hybrid, and community-based groups. 82% of participants completed their quarterly visits, and retention was 95% at the exit visit. So we were able to ascertain the outcome for the study. So here you can see the baseline characteristics of participants, and 51% of participants were men. So we were able to enroll men in the study with equal representation to women. You can see 55% of participants were aged 30 to 49, and the median CD4 count was 450. And here's the primary results of the study. For viral suppression, 63% of participants in the clinic group were virally suppressed, compared to 68% in the hybrid group and 74% in the clinic group. So overall, this gave us a relative risk for community versus the clinic of 1.18, and the clinic intervention was superior. For the comparison of hybrid versus the clinic, the relative risk was 1.08, with a confidence interval crossing 1, and this was non-inferior with a relative risk of more than 0.95. And the results were robust in multiple sensitivity analyses using a different cutoff for viral load, for example. So we used 20 for this primary analysis, but using 200 or 1,000, the results were unchanged. So overall, community-based ART increased viral suppression, and that was superior and significant in the study. When we looked just at the results for South Africa, 60% of participants were virally suppressed in the clinic group, 67% in the hybrid group, and 72% in the community group. So this gave us a relative risk of 1.26. And again, community-based ART was significant and superior. And for the hybrid versus the clinic group, it was non-inferior. So in South Africa, community-based ART increased viral suppression. When we looked at South African men, the rates of viral suppression were 51% in the clinic group, 65% in the hybrid hybrid group and 72% in the community group. That gave us a relative risk of 1.39 and relative risk of almost 40% higher viral suppression. And for hybrid versus clinic, this is now superior with a relative risk of 1.26. So among South African men, both the community-based ART approach and the hybrid approach increased viral suppression significantly, and it was substantial, almost relative increase of almost 40% for the community-based group. So when we look at viral suppression by gender in the clinic group, the hybrid group, and in the community-based group, we can see that community-based ART eliminated disparities in viral suppression by gender. So really no difference in the community group between men and women. And so now we have these exciting results on viral suppression. How do we present this data for decision makers? How can we estimate what the impact will be on health over time using these study data? And I'll just take a little dive now into talking about, just for 2 slides, the structures of math models and how we use these data to really harness these data to really drive mathematical explorations of the population impact of this type of intervention. And I love the slide. This is a model developed by Jennifer Smith, who is based in the UK and worked with us on this model, showing households here in the blue circles. In the green squares are men, in the yellow triangles are women. A solid red line is a stable partnership, and a dotted line is a temporary partnership. And so we have relationships within households, between households, within the community here in this dotted line, and outside the community. And so this is one perspective of the model. And then underlying that, for every individual in this model, we have their status. Are they susceptible to HIV? Are they living with HIV? Have they been tested, visited the clinic? If they have visited the clinic, what is their CD4 count? So when did they visit the clinic? And have they started antiretroviral therapy? And what is their CD4 count? And then we can use these data to simulate whether or not they're able to transmit HIV, depending on where they are in their natural history. And we can also use these data to simulate opportunistic infections and the costs of hospitalizations and opportunistic infections, and estimate the cost of treatment. And so building on that very initial model, this group of really outstanding students and trainees at the University of Washington, Cara Bayer, Alan Roberts, and Mita Sau, who went on to use the study data to estimate the cost effectiveness of community-based antiretroviral therapy. And they developed a deterministic compartmental model calibrated to South Africa, where HIV prevalence is 27%. And they modeled all adults aged 18 to 79 over a time horizon of 2020 to 2026. And they looked over 5 years and 40 years at the impact on population level HIV incidence, mortality, and prevalence, looking at standard services versus expanded services to include community-based antiretroviral therapy. And so the model is able to capture people who are susceptible. It captures the transmission of HIV, disease progression, ART initiation, and then viral suppression. And here are the results from the model. And this was quite exciting to see, because you'll remember that we saw an increase in the number of men who are virally suppressed. So what does this mean for ongoing transmission? And you can see here that for women, we see a big decrease in incidence here in this dark black line, a big decrease in incidence in the first 5 years, because the number of men on ART increases substantially. So there's a rapid decrease in HIV incidence by 35% in the first 5 years, and decrease in mortality by almost 40%. And similarly for men who are now on antiretroviral therapy, we see a dramatic decrease in mortality by 40% and a decrease in incidence by 35% by 2060. And so using the study data and the models, we were able to predict the impact on these population level health outcomes. So now we've estimated what it could mean in terms of health. Let's go on to estimate what the impact would be in terms of costs. And Meetha Sahu read this really nice health economic analysis where she defined the outcomes, working with the team, used microcosting data from the trial, did the math modeling, cost modeling, and then estimated the health economic impact. I just wanted to say just a couple of words about what outcomes we're using. And in this study, we use the outcome of a DALY, a disability adjusted life year. And this is a measure of the overall burden of disease. And it is expressed as the cumulative number of years lost due to ill health, disability, or early death. And here, 1 is perfect health, 0 is death. And you can think about DALY as a function that takes into account years of life lost due to premature mortality and years lived with disability. And the DALY weights for HIV health states are published, so we're able to use this. Oh, I'm sorry, and I had this backwards. It's 0 for there's no weight, of course, for being HIV negative, living without HIV, and death is 1. And then you can see for each stage, there is a weight, and the weight increases with CD4 count decreasing. And if you're on antiretroviral therapy, the weight again goes down. So we're able then to assign to each person or every compartment in a math model a weight, and then we can estimate the DALYs. And this assumes a life expectancy of 80, which is standard for this type of modeling. So using those disability weights, we can estimate the incremental cost effectiveness ratio, and that is essentially the change in costs over the change in health outcomes. And we take into account the total cost of the intervention, and we subtract from it the cost of the standard of care. And so this gives us the change in cost, the incremental costs. And then we look at the change in outcomes, the number of HIV incident cases that are averted in addition to the standard of care. So that's important to note that it's always incremental to the ongoing intervention. And we report the outcomes as the cost per DALY averted. And the cost effectiveness threshold in South Africa is $750 per DALY averted. So this is where we want to be in order to estimate whether something is cost effective. So within the trial, we were able to estimate viral suppression, and I shared those data with you. And in addition, we did activity-based microcosting to estimate what the cost of the care is. So we were able within the study to estimate the cost of having nurses, of having the mobile vans, of having the vans repaired and being able to pay for all the services, including testing. And we use the perspective of the health system. Since it's a universal healthcare, the perspective is the government payer here. And we used activity-based microcosting for the intervention. And we had a comparison with the literature for the standard of care. We estimated the annual costs, observed, programmatic, and efficient at scale. And the observed costs were what we did during the study. The programmatic costs were we were able to substitute using Ministry of Health salaries. And then the efficient at scale assumed higher client volume. But this higher volume was 8 clients being seen at the mobile van per day. And then here are the costs of in each of the 3 settings in the first year and in the subsequent years. You can see here the observed and programmatic costs. So at scale, overall, the annual cost per client was $249 per person per year. And how does this compare with the standard of care? in order to compare what we estimated in the study with the annual costs in the standard of care, we'll use math models. What is not reflected in the annual cost per client is how many clients are actually reached through the intervention. So we need to use viral suppression as a surrogate for the number of people for whom the intervention is successful. I'll remind you that we saw a decrease we predicted that we would see a decrease in mortality for men and a decrease in incidence for women over the first 5 years of the intervention. And then we were able to put that together with the costs. And so now we have the costs for people living with HIV who have incident or prevalent infection, and we can convert that to DALYs by estimating the impact on morbidity and mortality. For people living with HIV on ART, we have both costs and DALYs, we have deaths, and we also have DALYs for CD4 count. And we can put all this information into the model to estimate cost effectiveness. And we estimated cost effectiveness for 2 scenarios, providing the standard of care only, which is clinic-based antiretroviral therapy, or combining the standard of care, clinic-based antiretroviral therapy, with testing campaigns every 5 years and community-based ART for people who are not reached by the standard of care. I think this is really important to emphasize that it was not a change in the basic program that is provided, but an additional service for people who are not reached by the standard of care. So we were able to estimate reaching 4% of females through community-based ART and 29% of males. So you can see that this difference is driven by the number of people who are virally suppressed in the clinic to begin with. So what is the per capita annual cost of doing community-based ART compared with the standard of care? And here's the cost per capita. And here is the cost decreasing over time for the standard-based, clinic-based care, because of course, we expect that as more people start antiretroviral therapy, we'll see a decrease in incidence and a decrease in the number of people who need to be on ART. And with community-based testing, the initial costs are higher, and every 5 years when we have a campaign, the costs are higher. But over time, the costs do decline over time due to reduced prevalence. The next question we asked are the total costs affordable? And this is a critical question because something can be cost effective but not affordable. So the incremental 5-year incremental program cost $250 million for 5 years, an additional $43 million per year. The annual Department of Health HIV budget in KwaZulu-Natal is $312 million. And that translates to a required 14% initial investment in the HIV budget, which we thought was reasonable and feasible. And then we were able to put all this together to estimate the incremental cost effectiveness ratio. And so now we're comparing the change in costs with the change in health outcomes. And we estimated the cost per disability adjusted life year averted is $210, with a minimum of 196 and a maximum of 221. And this is well below the cost effectiveness threshold for South Africa, which is $750 per DALY averted. So you can see here, this is less than a third of the cost effectiveness threshold. So a highly cost effective intervention to reach people who are otherwise not suppressed at the clinic using community-based services. And so as you think about your own work and your own interventions, your own research, think about putting all these pieces together, defining your outcomes, using clinical data to be able to inform mathematical models, estimating costs, and putting the 2 pieces together to estimate cost effectiveness. So we were able to conclude that the scale-up of community-based ART is highly effective, preventing over 25% of HIV cases and deaths. It was affordable. Scale up requires an additional 14% investment, and it was highly cost effective at $210 per DALY averted. And then what were the next steps? So we were able to present these data both on the primary outcomes of the clinical trials and on the cost effectiveness. And the South African Department of Health now has 2 demonstration projects. They kept the name, so they called it the DO-ART project. It's run by the Health Systems Trust. And indeed, the project is even more innovative, and the team working on it are really focused on problem solving. So for example, now they have bicycles that deliver antiretroviral therapy, and they continue to do the monitoring outside the clinic. And so as these studies over the next few years, as these demonstration projects report the results, we'll have additional real-world data on community-based interventions. Also, the CDC recommends the DO-ART approach as one of the evidence-based structural interventions. So here in the US, and also UNAIDS has reviewed this and recommends community-based ART as a mechanism for differentiated service delivery for HIV care. So we're really gratified to see the kind of the next steps for this project move forward. So I'll just make a few comments as I wrap this up and make sure that we have time for questions. So today, I hope that I've shown you that infectious disease modeling is a useful tool that can be used to estimate health outcomes. You can use study data to parameterize models and estimate costs. And cost effectiveness analysis is a tool to help choose affordable, effective interventions. The comparator choice is important, and that helps us consider alternatives. Sensitivity analysis helps us deal with a lot of the uncertainty. Consulting with a health economist or a modeler will help with choosing the most appropriate model to answer your question. And you can integrate modeling and costing into treatment and prevention research to facilitate timely estimates of cost effectiveness, which are useful for decision makers. Don't hesitate to reach out to me with questions, and the CFAL website has a lot of information. We ran a series of workshops, and there is lots of written information and videos from all the workshops and all the materials on the CFAL website. I want to end by thanking the study participants, the fantastic team members, all the collaborators that I have had and continue to have the real honor to work with to assess the impact of community-based interventions, and of course, our funders. Thanks so much for your attention. I'll leave some time for questions. Please feel free to unmute or put questions in the chat.
So if you've got any questions or comments, please feel free to type them in the chat. There was a question earlier during the presentation, Dr. Barnabas, regarding the van. Do people in the community know that this is the HIV van?
Oh, yeah, so great question. Yes, so initially we thought about not having any branding on the van, but when we did our community-based preparatory work, the community advisory board said, everybody knows why you're there. It's better to be for you to have the name of the group, the study group on the van, and it really helps us identify what you're doing in the community. We do a lot of preparatory work, and that's really a critical and important part of the success of community-based interventions, so that when you are seen in the community, it's not a mystery to why you are there, and people are able to identify the van. We did offer other services at the van, and general health services, and we did screening for non-communicable diseases, hypertension, vision screening was very popular, and throughout the study we offered other services. But yes, the vans are labeled, and and people do know why you are there. And that I think, of course, will vary from community to community and should be the choice patients and in this case, study participants.
Any other questions or comments?
Great.
Oh.
Yeah.
Okay, I'm not seeing any questions or comments.
Great. I'm really happy to be back today, and don't hesitate to reach out if you have questions or comments.
Well, thank you, Dr. Barnabas, and it's great seeing you. Hope you know, the new position is going well, getting used to the new city. We hope to have you here in Seattle sometime soon at the UW. For everybody on the ACC today, just a reminder, we do not have an AIDS clinical conference in August. We'll take a month break, and then we will be back on the 3rd Tuesday of September with HIV and primary care with Dr. Jihan Budak. So thank you very much, Dr. Barnabas. Hope everybody has a great summer, and we'll see everybody back here in September.
Great.
Thank you.
Thanks so much. Bye-bye.